Okay, let's start this session. Title is Challenging Case Presentation 1. I'm Dr. Lim from Korea University, and my co-chair is Liwa Tam from Hong Kong. We have 5 expert panelists: Amin Arif Nuruddin, Saurabh Gold, Kenji Sadamatsu, and Hongru Huang, and Jun Fun. I'd like to introduce first 3 presentation topics, and next will be introduced by my co-chair Liwa Tam. I'd like to introduce first topic, ultra-low contrast unprotected left main PCI using IVUS and SEPAL technique by Dr. Christy Brillantes Carrera from Philippines. Please.
Warm greetings from the Philippines. I am Christy Brillantes Garganera, and together with my co-authors, we are privileged to share with you our case entitled Ultra-Low Contrast Unprotected Left Main PCI using IVUS and SEPAL technique. I have no disclosures to make. So our patient is a 60-year-old male hypertensive, poorly controlled diabetic, and with stage 4 CKD, presenting with easy fatigability, manages a case of ischemic cardiomyopathy, referred for coronary intervention. At the ER, his vital signs were stable as well as his physical examination findings. His 12-lead ECG revealed signs of bradycardia with poor R rate progression and no significant chest findings, with a creatinine of 251.40 and an eGFR of 23. Via the right radial axis, we used a 5 French catheter for coronary angiography, revealing a 4 mm left main with 65% mid to distal segment stenosis that bifurcates into the LAD and circumflex, a 3.5 mm type 3 LAD with a long 90 to 95% proximal to mid segment stenosis with mild myocardial bridging at the mid to distal segments, a 3 mm circumflex with a 30 to 40% mid segment stenosis, and finally, a 4 mm dominant RCA with a 70 to 80% distal segment stenosis just before the crux. Having planned ahead and reviewing the previous coronary angiography for the ultra-low contrast procedure mapping, we used a 7 French guide catheter and coronary wires were distalized to the LAD, circumflex, and first diagonal branch. An initial IVUS run showed concentric fibrofatty plaque in the LAD with an MLA of 2.08 mm squared, a distal reference of 5.46 mm squared, and a left main showing concentric mixed plaque with an MLA of 3.94 mm squared. Predilation from the mid to proximal left main using 2O by 20 mm compliant balloon was done, and a repeat IVUS warranted more predilation. Thus, we upsized to a 2.5 by 15 mm compliant balloon. Next, a Synergy 3O by 38 mm stent was deployed at the proximal to mid LAD, and to guide in the ostial stent placement, a SEPAL wire technique was done by withdrawing the diagonal wire towards the catheter, floating the catheter to allow the wire to advance to the left coronary cusp as a marker. We then proceeded with deploying the second stent, a Synergy 4O by 38 mm, positioned at the proximal LAD to ortho-ostial segment with a 4 mm distal overlap from the first stent. A pot of the left main using a 5O by 8 mm non-compliant balloon at high pressure was done. However, partial strut distortion was noted when jailed circumflex wire was pulled out, as seen in the videos B and C. Oscillation with a 3O by 15 mm compliant balloon of proximal left main to ortho-ostial area was done to allow IVUS to advance. IVUS showed stent under expansion at mid-LAD with partial stent distortion in ortho-ostial area, thus post-dilation using a 3.5 by 20 mm non-compliant balloon at the mid-LAD, followed by a 5O by 8 mm inflation in the ortho-ostial area, was able to correct the stent distortion as seen on the video at the right of your screen. Final IVUS showed complete stent apposition, no dissection, with an LAD MSA of 6.87 mm squared and the left main MSA of 12.57 mm squared with plaque burden of less than 50%. Post-angiography showed no residual stenosis or perforation with a TIMI-3 flow and a total dye contrast use of 10 mm isosmolar contrast. So for my discussion points, this is so far the first time that we were able to use the sample technique together with our ultra low contrast method. And we found out that it was a cost-effective method of ortho-ostial left main stenting done with this aid of this technique. And previous angiography shots used as roadmaps for wire placement and IVUS in replacement for contrast injection proved useful and effective as alternative for PCI in patients with high risk for contrast-induced nephropathy. For my conclusions, with proper planning, IVUS optimized ultra-low contrast PCI of unprotected left main with crossover stenting to LAD is feasible and can be safely done, especially in patients who are at high risk for having contrast-induced nephropathy. And IVUS was vital for assessment of vessel diameter, plaque morphology, adequacy of lesion preparation, stent sizing and length, and apposition of stent struts to vessel wall. Coronary wires were used as visual guides as to where we positioned our balloons, and stent coupled with IVUS in strategies such as the sample technique for ortho-ostial left main stenting to avoid geographic miss. Thank you for your kind attention.
Thank you for a nice presentation, Christy. This topic is open for panelists. Any question or comment?
Yes, Dr. Amin from Malaysia, from the National Heart Institute. Congratulations, a very nice case. A few questions I would like to ask. How many mils of contrast did you use? Number one. The other thing is, how long are you going to use double antiplatelet, considering that this patient has got renal failure and maybe a high bleeding risk as well? So these are the two questions I would like to ask.
So for our coronary angiography, the first procedure that we have 2 days prior to the planned ultra-low contrast, we were able to use around 50 mils of contrast. For this procedure, we were only able to utilize 10 mils of contrast, doctor. And for the dual antiplatelet, we hydrated the patient and we noted that there was improvement in the renal function. So since this patient has a high risk for stent thrombosis because of the morphology of the plaques that we were able to see, and of course the procedure, which was a left main stenting, we are planning to give the dual antiplatelet for 12 months.
Okay, thank you. Any other question?
This is Dr. Google from Mumbai, India. Dr. Christie, excellent case. Just wanted to ask you, the jailed wire which was in the circumflex, which you had trouble and which distorted the stent, did you remove it after the pot or before the pot?
Actually, we removed it after the initial pot.
So just a suggestion that once you deploy the left main stent at a nominal pressure, if you either remove the wire and recross it and then do the pot, that would, you could go through the stent back again after doing a nominal deployment, because once you've done pot, that stent is very well opposed to the wall, and you then have trouble removing the jailed wire. That was just an observation.
Okay, we have time limit, so thank you for a nice presentation, Dr. Christie. We are moving to next topics. Next topic is instant wave-free laser-guided coronary intervention in female prior to kidney transplant by Dr. Hendiono Lim from Indonesia. Please.
Good afternoon. I'm Hendiono Lim from Indonesia with my coworkers from Siloam Hospital Lipo Village and Faculty of Medicine in Pelita Harapan University, Indonesia. Thank you for the opportunity. Let me share a simple case of instant wave-free ratio-guided coronary intervention in female prior to kidney transplant. I have nothing to disclose. Patient female, 67 years old, came to our department with worsening dyspnea on effort a couple months prior to admission. She denied prior history of angina and also no prior hospitalization due to myocardial infarction. She has a history of well-controlled hypertension, type 2 diabetes mellitus, and also chronic kidney disease stage 5. She is on routine hemodialysis. The point is, patient already on schedule upcoming for kidney transplant procedure. From the evaluation, we do the ECG. We found patients still in sinus rhythm, normal axis, and some signs of left atrial enlargement and also left ventricular hypertrophy. And we can see there's a mild changes in ST segment and T-wave in precordial leads and also in inferior leads. From echocardiography, we found there's a left ventricle concentric hypertrophy with dilated right atrium and also dilated right ventricle. Also, there's a hypokinetic in left ventricle inferior wall with reduced ejection fraction around 37%, and also mild regurgitation in mitral and pulmonary valve. Due to her symptoms, we consider to perform the coronary angiography in this patient. The results we can see still normal in left main artery and also left circumflex artery, but there's a borderline stenosis in left artery descending artery, about 70% in mid. And also from the right coronary artery, we can see there's a mild stenosis in the mid, about 30% lesion. For the mid LAD, we see there's a borderline stenosis in the mid LAD with about 70-80%. So we consider to perform the intracoronary intra-atrial physiology examination with IFR. We inserted the guide wire in the mid LAD and the IFR. We can find the estimated guided pressure around 0.77. It means it shows the stenosis is flow limiting. So we decided to continue the procedure with a pre-dilatation balloon in the mid LAD and also the stenting with drug-eluting stent in the mid LAD. After procedure, we performed another procedure of IFR, and the estimated guided pressure shown increased to 0.98. It means the flow physiology already improved. There are some discussion points I can share from this case. First one, is it the hypokinesia found in the left ventricle wall, inferior wall in the echocardiography? Is it related with coronary angiography findings? In this case, we see the patients already in the condition of decreased left ventricular ejection fraction with the comorbid of diabetes mellitus and also chronic kidney disease. We know the diabetes and also CKD can associate it with improved development of myocardial fibrosis and also development of microvascular disease. For further examination in this patient, we can consider to perform the cardiac MRI to evaluate. And then the second point, is it necessary the coronary stenting in borderline lesion, specifically in female patient without significant clinical ischemic symptoms before? This patient also, we already stated, she's in the heart failure, reduced ejection fraction, and also with the imminent kidney transplant procedure. So we decided to do the intracoronary physiology assessment with IFR that provided the pressure gradients 0.77. It means the flow limiting stenosis, and the coronary stenting is needed prior to her kidney transplant procedure. The conclusion of this simple case, the IFR is easy to perform and also can improve the accuracy in coronary stenting decision. The IFR also provides lesson for specific data such as how long a stent is needed and how can a stenting improve lesion blood flow physiology. In this case, the PCI stenting in borderline stenosis lesion decision with IFR estimation can improve patient cardiac function prior to her kidney transplant procedure. That's all my presentation. Thank you.
Okay, thank you, Dr. Lim, for nice presentation. There any question or comment for this topic?
Okay, I'm Kenji Sadamatsu from Japan. I totally agree that IFR is a very useful and treatment to LAD, but hemodialysis patients is excluded in all randomized study using IFR because resting coronary flow in hemodialysis patients is increased. vessel flow is increased. So it is not difficult to assess the resting flow in hemodialysis patient. Did you measure FFR in this patient?
No, we didn't perform the FFR in this patient. Prior to the procedure, we discussed with patients. She already transferred from the hemodialysis center to our department. At that point, the condition is stable with no volume overload and no further symptoms of the failure symptoms. So we discussed, and also consideration of the procedure and technique. So we decided to perform the IFR, and the flow limiting stenosis, and also after procedure is so significant improvement of the physiology flow in the coronary artery.
Other question?
Yeah, in that case, you use the IFR to guide PCI for the borderline lesions. So I have a question. For this case, ejection is only 37, but in your history, there's no myocardial infarction or the myocardial infarction, right? So what's the patient, the ejection fraction is very low. Do you have just do some MRI for the patient, or some echo contrast test to find out, let's say, the myocardial infarction or not?
For this patient, from the point of discussions, we need to consider to perform the cardiac MRI, because from the echocardiography, we can see the regional wave movement. It's in the inferior lead. It's from the angiography, it's in the LAD region. So we still think that this patient, we need to perform the cardiac MRI to evaluate, is it the prior ischemia, infarction, or probably also the myocardial fibrosis caused by the comorbids such as of chronic kidney disease in these patients. So we still need to further examination in this patient.
So what is your anticipate strategy for kidney transplantation?
For the transplantation, this patient, after the PCI of in the AID, his improvement, and also still continue for the hemodialysis, waiting for the procedure of the kidney transplant. We still improve in the therapy, optimization therapy for the heart failure, and also the antiplatelet considerations due to prior of his operation. So we need to evaluate the risk of bleeding and also the risk of stenosis prior to her operation.
Okay, thank you. Thank you, Dr. Lim.
Thank you very much.
We are moving to next topics. Topic is double culprit STEMI by Dr. Chun-Lin Raymond Chung from China. Please.
So good afternoon, everyone. This is Raymond from Tuen Mun Hospital from Hong Kong. I'm glad to present in the Complex PCR 2021 this year. The topic I'm going to share is about double culprit STEMI, and I have nothing to disclose. So this is our patient, 61-year-old man who attended our hospital for acute onset of chest pain with sweating and nausea. We can see that from the ECG, there is ST elevation over the inferior leads, lateral leads, and also the right side involvement. ECG also show complete heart block with wide QRS complex. Initially, the BP of the patient was stable around 140, but soon he developed a crash. BP dropped to around 50 to 60. Anotrope was immediately started. The heart rate is around 30 to 40, and CCU was urgently consulted, and he was directly sent to the cath lab for primary PCI. This is the coronary angiogram of the left system. We can see that there's a total occlusion over the LAD. There's also some minor disease over the circumflex artery and also the left main artery. This is the coronary angiogram of the right system. We can see another total occlusion at the mid-RCA. So in summary, our patient has a difficult situation where he has total occlusion involving both LAD and RCA. we believe that he will develop into cardiac arrest in a short time because of his unstable BP and also complete heart block. So what action should we do next? Either to proceed to PCI first or do mechanical circulatory support first? We don't know because there's no definite answer. So since the patient has RCA involvement, we believe that he has a component of right ventricular failure. So if mechanical circulatory support is needed, ECMO would be a choice. The time to set up ECMO depends on the manpower and the resources of different center. In our center, we have to call our ICU colleagues to set up the ECMO, and the time required is around 20 to 30 minutes. On the other hand, we estimated that we can do the PCI between 10 and 15 minutes. So we decided to do PCI first because we think that it is faster. So we started with PCI to the RCA, which is quickly wired and pre-dilated with 2.0 balloon and stented with a 2.5 stent, and the coronary angiographic result is satisfactory. Following that, we proceed to PCI to LAD. The LAD is quickly wired, pre-dilated with a 2.0 balloon and stented with 2 overlapping 2.5 stents. The angiographic result is also good. However, despite our effort in revascularization, the patient's BP was persistently low, around 50 to 60, upon leaving the cath lab. So finally, we call our ICU colleagues to set up the ECMO with the sheath, and also we also input the impeller for LV venting. There's actually growing evidence that combined use of ECMO and impeller, also known as ECPella, can improve patients' outcomes. A study published last year showed that ECPella can have better mortality and reduce better neurological outcomes comparing patients with ECMO and IBP. So after a few days, echo show improving ejection fraction from 15 to 30%. After 4 days, we decided to proceed to stage PCI for optimization before weaning off the ECMO. So since both of the femoral access have been used for ECMO and impeller respectively, there's no extra site for us to puncture for the PCI. So we decided to puncture through the ECMO sheath. First, we sterilized with chlorhexidine first, and then to do PCI in a usual fashion to puncture with a needle and thread in the guard wire, and later put in the 6 French sheath for our PCI. So we proceed to PCI to RCA. IFAS show distal stent landed on plaque. Therefore, we decided to deploy another stent with overlapping with the previous stent. Good angiographic result was achieved finally. And then next, we proceed to PCI to LAD. IFAS show mild stent under expansion. Therefore, we perform post-stent high pressure with 2.5 and also 3.5 balloon serially. And finally, another good angiographic result was achieved. So ECMO and impeller were subsequently removed from the patient, and we stepped up the anti-heart failure medications. The ejection fraction recovered to 35%. The patient was ready to be discharged after 1 month of multidisciplinary cardiac rehabilitation. So in this case, we saw a difficult scenario in which a patient has a double culprit STEMI involving the LAD and the RCA with unstable hemodynamics and high chance of developing cardiogenic shock and cardiac arrest. In dealing with these situations, whether to use MCS first and revascularization first, there are actually a number of factors to put into consideration. For example, the hemodynamics, the complexity of the lesion, the type of MCS required, the time to set up the MCS, and etc. Depending on the situation, different case, we may have different strategy, and it should be on a case by case basis. In this case, we believe that we can do PCI faster than setting up ECMO. Therefore, we decided to proceed to PCI first, and eventually the outcomes were favorable. So it comes to the end of my presentation, and thank you for your kind attention.
Okay, thank you for nice presentation, Dr. Cheng. Any question or comment for this case?
Yeah, Dr. Amit from Malaysia again. I must congratulate you to handle this patient in a very timely manner. A few things that I wanted to know: was there a big thrombus burden when you open up the left and the right system? Does this patient have any coagulation problems? And thirdly, from our personal experience here, sometimes those who had COVID in the past may present with this hypercoagulated state. And we have also seen some patients with certain vaccines that present with hypercoagulated state. Any of those things in your patient?
During our first PCI, the LAD and RCA was found to have acute total occlusion. There is actually quite a lot of plaque burden. Therefore, we decided to settle both of the vessels in a stage PCI. There is no known coagulation issues in this patient, and prior his admission, there is no recent vaccine injection.
Yeah, thank you. This is a very nice case, a complex case, because this patient has double carbureted vessel occluded and undergone cardiac shock. So I agree with that. Sometimes different patients have different strategy. For some patient, if this patient maybe looks some stable, you can do PCI first, or maybe the lesion is very easy to do. We can do the PCI first. Sometimes the lesion is very complex, so maybe we should implant ECMO first. Or sometimes I mean that the carburetor very recurrent unstable, or sometimes recurrent cardiac arrest. So we need to implant ECMO first. So I have a question. So if this patient has double carburetor lesions, so which one should we do first, LAD or just RCA? Because usually LAD just supply a larger amount of the cardiac cells. So should we just do LAD first, or maybe sometime RCA first? That's a question. Thank you.
So because from the initial ECG, we show that it is ST elevation over the inferior leads, and also with complete heart block. So initially we believe that the culprit is the right side. Therefore, we start to do the coral from the non-culprit side at the time, which is the left side first, and then we put the guiding catheters into RCA for diagnostic and also for PCI. Therefore, we started to do the PCI from the RCA because the ECG shows more suggestive of more acute RCA involvement.
Okay, thank you for nice presentation, Dr. Chung. Okay,
Yes,
Dr. Lee or Tom, please.
Thank you, Dr. Lim. So our next presenter is Dr. Mohammed Shafar Parvez. She's from Bangladesh. So the title of our presentation is a simple cutaneous coronary intervention may complicate unexpectedly. Aortal coronary dissection treated with non-covered stent across the ostium. So Dr. Parvez, please.
Thank you, honorable moderator and panelists and other presenter, and dear audience. Good afternoon. I am Dr. Shafiqur Rahman Patwari from the Bangladesh. My case is a simple percutaneous coronary intervention may complicated unexpectedly. Aortocoronary dissection treated with non-covered stent across the ostium. I have nothing to disclose. And the history shows that Mr. X, 46-year-old gentleman, hypertensive, non-diabetic, smoker, presented with ischemic chest pain for the 6 hours. Our examination shows that hemodynamic is stable, and that he had a fast history of the inferior wall ST-elevated microinfarction treated with thrombolytics 1 month back. And biochemical test shows the normal within the normal range, and electrocardiogram shows the OMI inferior, and echocardiogram shows that is ejection fraction is 62%, and inferior wall hypokinetic in echocardiogram, and diagnosed as a case of the old microinfarction inferior with unstable angina with hypertension. And coronary angiogram reveals the normal left main coronary arteries, and there is a minor plaque in the mid part of the LED, and LCX is normal and non-dominant, and there is a 30% stenosis in the mid OM1, right coronary artery dominant, and there is a 99% stenosis in the proximal part of the PDA, and we plan for the PCA to the PDA. This coronary angiogram shows there is a mild lesion in the LED, and then the OM1 has the 30% stenosis in the mid part, and the RCA that is 99% stenosis in the proximal part of the PDA. And we start the intervention with 6 strands right Dutkin guide catheter, and use the wire that is Tenimo run through wire, and pre-dilatation done with 2 into 12 millimeter semi-compliant balloon at 8 ATM. And this is the guide wire and the catheter we used during the procedure, and the pre-dilatation with 2 into 12 millimeter semi-compliant balloon. And then we stent the PDA lesion with the resolute integrity that is 2 into 2.25 into 30 millimeter stent at 8 ATM. And during deployment of the stent in the PDA, radiological feature of dissection of the RC in the proximal and the mid part C, and is more obvious thereafter, and gradually to stent proximally to the ascending aorta, and creating a type A dissection, DeBakey type 2 or Dunning class 1 dissection in the aorta, and distally it also extend up to the that is deploying stent in the PDA, and the patient was hemodynamically compromised, and this shows that there is a RCA after the pre-dilatation. There is a flap in the proximal part of the RCA, and here after stent deployment, during stent deployment, there is a radiological feature of the dissection of the proximal and mid part of the RCA. After PDA stenting, dye held up in the ostium as well as the dissection plating in the proximal part, and the flow compromising the distal part of the RC, and it also extends into the aorta, ascending part of the aorta, and creating the type A dissection or Dunning class 2 dissection in the aorta. And to prevent the further extension of the first we deploy the drag-limiting stent, that is Orsuru stent, 3.5 into 40 millimeter stent in the osteoproximal part and the osteoproximal and mid part of the RCA. And after deploying the first stent, patient improving his hemodynamic status, and another stent that is 3 into 40 millimeter stent also deployed in between the first and second stent, and upper flap of the aortic dissection disappear after this procedure. That is here showing the to prevent the further extension to the ascending aorta, we deploy the first stent in the osteoproximal and the mid part of the RCA, and another stent deployed in between the first and second stent. After completion of the procedure, patient was hemodynamically stable, and the angiography will show the no further extension in the ascending aorta. And during the PCA, unfortunately, simple procedure may turn into a more complicated scenario involving the dissection of the whole RC, including the ostium and ascending aorta, creating the type A dissection of the aorta. We would attempt to approve further retrograde extension to the ascending aorta by deploying non-proper stem across the ostium. So good control of the retrograde flow was obtained. And we follow up the patient with transthoracic echocardiography and showed no evidence of the aortic regurgitation pericardial effusion. And my discussion point is, what is the ideal way of treating the aortocoronary dissection and have any role of imaging? Is there any evidence-based guideline to assist the operator in treating the catheter-induced aortocoronary dissection, and how such catastrophe can be prevented? Take-home message, that is, aortocoronary dissection during the PCI is a rare but life-threatening complication. Management of the dissection propagating to the ascending aorta is challenging. Rapid recognition is essential to employ potentially life-saving management technique in a timely manner. Prompt treatment with conventional non-cover stent for the aortocoronary dissection may be life-saving. Thank you all.
Thank you, Dr. Perry, for this challenging case. Now it's open for discussion. So any comment from the panelists?
Yeah, basically, if this sort of dissections may occur if you use an M-Plux catheter, the risk is higher. Maybe how do you sort of monitor this dissection? Are you happy after 24, 48 hours to just leave it alone, or do you sort of look at these patients again in terms of the dissection?
So how you monitor the dissection?
Yes, how would you monitor? Because I think from what you say, after 48 hours, you're quite happy by the transthoracic echo. And you, how do you monitor later? Do you monitor them later? Do you repeat the angiogram or CT scan later?
Dr. Perry, do you have your, repeat the CT or angiogram for the patient?
No, we cannot do the CT angiogram of this patient. We follow up the patient with the echogram, transthoracic echocardiography only, as because with the transthoracic echocardiography, we found that there is a sealing of this dissection, and there is no pericardial effusion or aortic regurgitation. For this reason, we cannot proceed for further imaging procedure.
Thank you.
I think during my experience, the orifice dissection more occur in the RCA, and especially you have a deep sitting catheter. So I think the important one, you must shoot one proper catheter to avoid deep sitting during your intervention. And you must carefully monitor the vital signs to check the EKG change during procedure.
Yes, thank you, Dr. Hong. I guess for this type of dissection, if happen, I guess the very good advice is not to inject further. So probably we should stent the possible part as early as possible in order to prevent the extension of dissection. Most of the case, it can be, suited with ordinary stent because it's just dissection, not really perforation. Okay, in the interest of time, I guess we have to move on to the next presentation. So thank you, Dr. Perry, for showing this challenging case. So the next presentation will be presented by Dr. Chen Chun Wai from Taiwan. So the title of this talk is Double Banding and Calcified LAD Lesion Treated with Motivation. Dr. Wai, please.
I have nothing to disclose. My patient is a 76-year-old female who presented with unstable angina for weeks. She was a victim of end-stage renal disease and underwent hemodialysis for over 20 years. This is her angiography. You can identify severe calcification along the vessel, and there is a tight stenosis in the middle part of RCA. And the circumflex was totally occluded. And for LAD, you can find some severe calcification with large angle. Let me show it again. So I decided to treat this patient with rotablation, and I set the platform at a proximal LAD and ablate the proximal lesion, the proximal angle smoothly like this. However, the 1.25 millimeter Burt could not pass the second banding. Yeah, what should we do? Actually, we have several choices. In this situation, we can use extra support wire or small balloon or tonus catheter. However, what we did at that time was just to upsize our rota Burt to 1.5 millimeter. And after several rounds of ablation, the 1.5 millimeter Burt passed the second bending. Yeah. Then we did balloon angioplasty with high pressure balloon. We stent the distal LAD first, and after stenting, some no reflow phenomena occurred due to distal embolization. We performed thrombus aspiration and deploy another stent in the proximal LAD, and the result for LAD was not so bad. We also treated the RCA. Yeah, we put the temporary pacemaker and start with 1.5 millimeter Burt because our IVUS catheter could not pass. And this is the IVUS image, which shows the MLA after 1.5 millimeter rota ablation. Then we upsized to 2 millimeter Burt because the RCA was a huge vessel. And this is the MLA after 2 millimeter Burt ablation. This is the final angiography for the RCA. So what is the rationale for upsizing to 1.5 millimeter Burt? For 1.25 and 1.5 millimeter Burt, actually they have the same long axis length. And in the bending zone, their crossing profile are almost the same, like this picture. However, 1.5 millimeter Burt can ablate more tissues than 1.25 millimeter Burt. This is the illustration. The 1.25 millimeter Burt can penetrate the horizontal part of calcium, but stuck in the bending zone due to small space around the Burt. However, 1.5 millimeter Burt has almost the same crossing profile in the bending as 1.25 millimeter Burt, and it can create more larger space around the Burt. So 1.5 millimeter can cross the bending, the calcified lesion. So my conclusion, calcified and large bending lesion is always challenging. And upsizing the Burt size can be an option for uncrossable calcified lesion with large angle. Thanks.
Thank you, Dr. Wang, for this beautiful illustration. So any comment from our panelists?
Doctor, it was a very challenging case, and you demonstrated very good use of rotablator in LAD as well as RCA. Did you consider IVL, the intravascular lithotripsy, in this case? Because the bends are always a challenge when you are trying to do rotablator. IVL, intravascular lithotripsy.
It's not available in Taiwan in current stage, so it's not an available choice for me.
Because it's a very, very good choice in these kind of lesions, big vessels with bends. You get, you can break the calcium. Sometimes even with rotablator, you cannot reach the deep-seated calcium, where IVL breaks it very nicely.
However, I guess the crossing profile of short-wave balloon now is not that great. So I'm worried that the short-wave balloon may not able to cross that, bending and calcified lesions.
I think, sorry, I agree with both of the panelists, is that IVL, the crossing profile is not that great, but sometimes if you need to just inflate or open up the lesion a bit more with a smaller balloon, you may be able to pass. I think it's a much more, it works quite well actually, IVL, if you can cross the lesion. And I think the risk of perforation and all that is much less compared to the rotablator, especially when you have these acute angles. But definitely, for those who have used IVL, I think there are lesions that are better off using IVL compared to the rotablator. Thank you.
Yeah. Very interesting case. Because this patient has a very severe cassette and also have a large bed for the LAD. So it's a very interesting idea to say that you can upsize the size of the rotor just to cross over the band calcified ledges. But I think sometimes it's very dangerous to upsize the size because sometimes there's a wire pass to some other side of the lesion. So sometimes induce the dissection or some induce the rupture of the lesions. I think they're dangerous. So how do you think to avoid such kind of less complications if you upsize the size of the burr? Thank you.
Yes, I agree with you. To upsize the burr size sometimes may create some complications such as perforation. So that's why I didn't use extra support wire, because I believe extra support wire may create more unfavorable wire bias. So for this case, I use just the rotaflopy, and I perform my ablation with 1.5 millimeter burr very smoothly, like a cruising motion and not a packing motion. So that's what I can did to minimize my perforation risk, I think. Thank you.
Thank you. Changing the burr size is good solution, but use of guide extension catheter is another option, I think. Yes. Insert a guide extension catheter deeper and ablation.
Yes. Thank you very much.
Yes, thank you for the presentation and also for the opinion from the different panelists. So we come to the last presentation. It was planned to be presented by Dr. Hardana K. Bailey from India. His title is the endovascular reconstruction of a chronically occluded venous graft using combined antegrade and retrograde injection.
Hi, good afternoon. I'm Dr. Harinder Bali, Chairman, Cardiac Sciences, Paras Group of Hospitals, India. I will be presenting a case of endovascular reconstruction of a chronically occluded saphenous venous graft using combined antegrade and retrograde injection. I have no conflict of interest to declare. Post-CABG patients constitute almost 5 to 8% in all centers who are taken for angioplasty. Native vessel angioplasty is preferred in most patients because it gives a long, very good results. SVG interventions are commonly carried out, but they do not have as good long-term results as native vessel angioplasty. However, in some patients where it is not possible to do native vessel angioplasty, endovascular reconstruction of chronically occluded SVGs may be the only available option. We describe a patient in which antegrade approach was combined with a retrograde injection to successfully reconstruct the diffusely diseased and chronically occluded SVG graft. My patient is an 85-year-old male, known case of coronary artery disease. He had undergone a bypass 20 years back. At that time, lima was anastomosis to LAD. It also got a SVG graft to obtuse marginal and an SVG graft to PDA. He had been asymptomatic, but for the last 6 months, he was getting increasing angina. And at the time of presentation, he had class 3 angina. On echocardiography, he had an ejection fraction of 35% with regional wall motion abnormality in right coronary and LCX territory. Angiography was done to the right femoral root and GL6 French, JR 6 French, AR1, and Lima catheters were used to do angiography. On coronary angiography, left main was normal. LAD after diagonal had 100% occlusion. Left circumflex was a non-dominant vessel. Proximally, it was 100% occluded. And distal circumflex and obtuse marginal were filling through intracoronary collectors. Native right coronary was 100% occluded at ostium. Posterior descending artery and PLV were filling retrogradely through the left injection. Graft angiography showed that the Lima to LAD was patent, SVG to obtuse marginal was patent, but SVG to PDA was diffusely diseased from ostium and was 100% occluded at the anastomotic site. So the final impression was coronary artery disease, native 3-vessel disease, Lima to LAD patent, SVG to obtuse marginal patent, diffusely disease, and chronically occluded SVG to PDA. So we decided to take him for angioplasty, considering his class 3 angina. And native vessel right coronary angioplasty was not possible, so we decided to do an endovascular reconstruction of the chronically occluded RCA SVG. We chose both the right femoral and the left femoral root and 6 French sheath. This patient was given unfractionated heparin 10,000, and he was loaded with clopidogrel 600 milligram and aspirin 150 milligram. Guide catheter was JR 3.5, and for the left coronary system, we chose the JL4 diagnostic catheter. Guide wire was Fielder XT, and this patient, after crossing the lesion was dilated with 1.5 into 12 millimeter splinter balloon, and subsequently with 2.5 into 15 millimeter balloon. And we had to deploy 3 stents to reconstruct the whole vessel. Science Expedition 2.5 into 48 millimeter, 3 into 38 millimeter, and 3 into 38 millimeter stents. The stents were post-dilated using 2.5 into 15 millimeter NC balloon, and then 3.5 into 15 millimeter NC balloon. And post-dilatation was done at 28 Mosley. The final result was a successful endovascular reconstruction of the chronically occluded SVG graft. This is the angiography, and you can see the right coronary SVG graft is diffusely diseased right from the ostium, and then in the mid segment at this anastomotic site, which is chronically occluded, and there's no vessel visible distally. We tried to cross this lesion antegradely by using a Fielder XT wire, but distal, we couldn't cross the lesion. And in fact, there was small pulp, but then we decided to use both the femoral root to see the retrograde vessel. And this is the left coronary native angiography, which shows that the PDA is filling retrogradely. And this is right coronary or cranial view, and the epicardial view also showing that the PDA is filling retrogradely. And using that as the vessel, site of vessel, and directing the Fielder XT wire, we were able to cross this lesion reasonably easily. And as you can see that the Fielder XT wire now is very well positioned in the PDA branch, and we were able to cross nicely. And then we dilated this lesion first with a 1.5 millimeter splinter balloon, and then with 2.5 into 15 millimeter splinter balloon. And the entire length was dilated at 15 to 16 atmosphere, and we got a good antegrade flow. And then we went ahead and deployed 3 stents. As I already mentioned, Science Expedition stent was used, 2.5 into 48 millimeter, 1 stent distally, then telescoping into it, 3 into 38 millimeter, and another 3 into 38 millimeter right at the ostium. And the entire vessel was reconstructed. We post-dilated this lesion with 2.5 millimeter into 15 millimeter, and then 3.5 into 15 millimeter NC balloon at 20 millimeter atmosphere. And you can see that now we have very nicely fully reconstructed SVG graft to right coronary with nice filling of all the branches. There is no residual stenosis, and there is no dissection, and the flow is very good. TV3 flow was achieved. So in conclusion, I would say that chronic total occlusions present one of the most challenging lesion subsets faced by the interventional cardiologists. CTO is a common problem. It's being present in more than 30% of patients undergoing coronary angiography in elderly people, and in post-bypass patient, even 55% patient, 50 to 55% may have CTOs. Dual injections are very important in defining ambiguous anatomy, and in fact are used in most CTO interventions. We describe a patient in which the chronically occluded SVG graft was reconstructed using an antegrade approach and a retrograde injection to define the direction of the artery. Patient is clinically asymptomatic with very good effort tolerance at 4 years of follow-up. So we conclude that in symptomatic patients on maximally tolerated treatment with no options, endovascular reconstruction of chronically occluded SVGs may be a reasonable option for relief of symptoms and improvement of life, quality of life. Thank you. Thank you very much.
And I guess all of you will come quite with me that today is a very fruitful discussion and very interesting case being presented by different presenters from different parts of the Asia Pacific region. So on behalf of CRF, I would like to thank all the presenters for presenting the cases and all the panelists for contributing their expert opinion in treating this complex lesion. Of course, I have to thank my co-moderator, Dr. Lim, for the kind chairing of this session with me. So finally, I would like to thank the CRF for organizing this platform for us for discussion. With that, I conclude this case presentation session. So thank you all for joining us. Thank you.
Thank you.
Okay, thank you.
Thank you. Bye-bye.